We have three panelists tonight. We have Melanie D'arrigo, the new executive director of Campaign for New York Health. We have a health economist, Peter Arno, and we have the film director, Vince Mondillo, with us tonight. And we'll give each of you a chance to introduce yourselves in more depth in a second. But Melanie, if you could kick us off, that would be great.
Thank you, Jeff. Hello, everyone. As Jeff said, I'm Melanie D'arrigo. I'm the new executive director for the Campaign for New York Health. I spent my career in preventive health, building population health management strategies and implementing programs for organizations all over the country. I'm also a two-time congressional candidate, and I'm an organizer. So I'm taking the culmination of all my experience and work and pouring my heart and soul into the Campaign for New York Health to pass universal health care at the state level for all of us. Thanks, Jeff.
Thank you, Melanie. And Peter, if you'd like to go next.
Yes, hi, I'm Peter Arno. I'm a health economist at the Political Economy Research Institute, or PERI, at UMass Amherst. And for the past few years, I've been working with my colleagues at PERI on the economic and financial analyses of universal health care. We did it for the United States, for the state of California, and we're currently working on New York with an analysis of the cost, the savings, and the financing for the New York Health Act. Thanks.
Thank you, Peter. And Vincent.
Hi, I am the director of the movie, producer, writer, etc. And actually, before I make any comments, I want to give a special thanks to Peter Arno, who was not only in the movie, but on an ongoing basis. We've had many conversations. It's helped along the way. So this is the fourth film in a series. We started with a single payer film called Fix It. Then we dealt with Big Pharma, which was about pharmaceutical prices. And then we dealt with the root of all evil, money and politics. And now this is the final film, which to me is particularly important because we all know that any discussion of single payer, really part of the solution is payment reform. I think it's virtually impossible to try to overlay single payer into our current system, which is, needless to say, a Byzantine thing that could have been designed by Kafka.
Thank you, Vincent, and thank you for this amazing film. It's powerful, it's informative, it's enraging, and hopefully inspiring as well. And I'm glad that you toward the end of it suggest some solutions. But I do want to direct the first question to you tonight. You answered part of it just now, like what led you to move from the way we pay for healthcare, which is terrible and dysfunctional on its own, to the hospitals that provide that care. What was the link in your mind, and why was it important to tell that story? And just to focus the question a little bit more, as you probably know, I think people generally have a very favorable view of their hospitals and of their doctors. Of course, there's a big asterisk next to that. That depends on your income level to some extent, your race, where you live, and of course how sick you are, because people don't get a sense for how dysfunctional our system is until they get really sick. But given that public perception, was it important to you in making this film and moving to the hospital part of the equation to tell that part and make it clear that it's not just the insurance companies, the pharmaceutical companies, and so on, but the larger sort of corporate nightmare that has become modern America that is at the root of the problem?
Well, this film was certainly much more difficult with doing single payer, because frankly, I've yet to figure out the value of health insurance companies, to be blunt about it. Big Pharma is also a rather blatant price gouging violator of the public. But with hospitals, it's such a mixed bag, and it's so complicated. And that's part of the reason the public and even the media has not put much of an eye on them, is because most people don't know what's going on under the hood. I mean, all we know is if you go to the hospital, you get a crazy bill, endless pages, and maybe the $10 Tylenol. But we don't really understand what's going on with hospitals. So from our point of view, it was really important to deal with that part of it. And again, to say, yeah, you might be getting great care at your hospital if you have access. But, you know, what I've been saying lately is it's like saying, I have a great mechanic. He can fix anything that goes wrong with my car. He does a phenomenal job, or she. Well, okay, what about the fact that they charge twice as much to fix it than the car is worth? So this has been the dilemma with hospitals, is they're providing often an incredibly valuable service, good quality, but the costs are totally out of control. And I wouldn't say it's totally the hospital's you know, fault, because obviously insurance companies play a huge element in that, but hospitals have been pretty much ignored in terms of their participation in the problem. So we wanted to take a look at that and really change people's perceptions of hospitals. Now, when you go by a building that's going up, you might have a different idea than normally feeling good about it.
Yeah, absolutely. Thank you, Vince. And actually, it's sort of a follow-up question for Peter. You've also made this link more a part of your work between our payment systems and the provider side of the equation. What led you to look more deeply into that? And you know, what is would you say the relationship between the hospital, the dysfunction with our corporate hospitals, and the way we pay for healthcare and providing health, and what would providing universal healthcare do for that?
Well, as the movie described, and Vince just described, you know, and Elizabeth Rosenthal in particular in the movie, hospitals have gotten a relatively free pass in terms of public scrutiny. You know, health reformers have focused on the drug industry, the pharmaceutical industry, worthy things to focus on, but hospitals, and I just thought it's worth mentioning, consume the largest part of our healthcare dollar. 1 out of every 3 healthcare dollars is spent on hospitals. That's huge. And also, as Vince mentioned, the entree to a universal single payer type of reform has got to be on the payment side of things. And under most single payer proposals, including the New York Health Act, the 2 biggest potential sources of savings that could accrue to such a system come from 1, lower drug prices, and 2, reducing the bureaucratic administrative burdens that are contextualized within our system, largely from the insurance industry, but they resonate throughout the entire system. And a large part of those administrative expenses and the potential savings under a universal plan can be found in hospitals. And so that is the link. And if I could just add one extraneous thing, I just looked at a published analysis of the top 40 hospitals in New York, and what they found was that of those 40 hospitals, there were 122 executives at these hospitals that were paid over $1 million a year. And the average was closer to $2 million. And this data was from 2020. And so I think in order to achieve a fair, equitable, and financially viable universal healthcare system, we have to address the elephant in the room, and that is the American hospital. Thanks.
Yeah, that's a great point. As long as the incentive is there, there are going to be people who respond to that incentive, and if the incentive is profit, that's what they're going to focus on rather than giving people care. And this is actually a great segue to my first question for Melanie. Melanie, if you could tell us a little bit about the Campaign for New York Health, what it has done, what it's doing, what it plans to do. And also I want to link this with make it a 2-part question, and I'll also ask you about a challenge that I think we find. in motivating people to get involved with the struggle for universal healthcare. I think most people have a sense that there's something deeply wrong with our current system, that they don't know exactly where to place the blame or know what to do about it. So how does the Campaign for New York Health Act figure into that, and what are the, how do we respond to that challenge?
Yes, thank you. Well, so for those of you who don't know, the Campaign for New York Health is a statewide massive coalition comprised of grassroots organizations, nonprofits, legislators, faith-based organizations, and regular folks who are trying to make a difference. We are growing every day, and our mission is to pass the New York Health Act. So that's kind of a bit about who we are. There's been a considerable amount of work done over the years to educate folks, to bring in and grow the coalition. I think, certainly my predecessors get my hat tip. They've done a lot of work to build an organizing foundation. And now I'm here to kind of take the campaign to the next level. So we are working on a variety of strategies. And frankly, we're going to be really surgical and make sure that all of our strategies are intersecting. We definitely will have a very streamlined organizing strategy, legislative strategy, a union strategy. And if I didn't mention, we have plenty of unions in our coalition as well. We are also working on a segmented communication strategy. And so, Jeff, when you ask, how do we get folks motivated, right? Well, not everyone is the same, and I think many folks, if you've tuned in here tonight, you're probably familiar with terms like Medicare, deductible, coinsurance, premium, Medicaid, Medicare Advantage. The average person, unless they're in a certain age demographic, has not heard about that, right? So I think we've got to start to get a bit more creative in certainly speaking to not only demographics, but different geographical areas and speaking to their issues. Right now, what's happening across the state, we should all be terrified. I found out last night that the maternity ward in Rensselaer County, the only one left, is closing. They are closing mental health services, with the exception in that same county of residents in Troy. There's a merger with the last public hospital in Suffolk County on Long Island. And of course, many of us are probably aware of the fights that are happening at the public hospitals in New York City to pay their nurses a fair wage. Now, if it doesn't hit you directly, if you're not aware of it directly, you're probably not paying attention. So we've got to get creative in terms of really being very proactive in expanding that coalition. And I think that's through segmentation and making sure we're addressing the needs of those particular geographic areas as well as demographics.
Thank you, Melanie. And with that, I think I'm going to open. So we've been collecting your questions in the Q&A. Catherine, if you could share some of those with our panelists, that would be great.
Probably would help if I unmuted. There are a lot of questions, not surprisingly. I think the first question that came in was for Peter Arno. In your opinion, which country has a model that would work best in the United States and/or New York? Easy question.
Well, I really don't know the answer to that question, but I would say that, we've had a debate over the years, state reform versus national reform, and which is the most, which is the best way and which one should we support. And there was a lot of people on both sides of this issue. And in my view, I think given the politics at the national level these days, state reform has the most potential at this time. And this was, just to get to your question, reminds me of what happened in Canada, right? It occurred in one province originally and spread to the other provinces over a few years. And if New York and California were to pass their single payer bills, that would undoubtedly lead to a domino effect in the other states and then ultimately the national level. So, I mean, I just throw Canada out as an example. The one problem Canada has, and we should never fall into this trap is that they don't cover drugs in their national health plan, and that hopefully will get changed in the next year or two, but that's something that needs doing.
A lot of people are concerned about the role of unions in terms of the passage of the New York Health Act. So people want to know why there's resistance from the unions, and they'd like to know if there's a list of unions that are supporting the New York Health Act. So I think probably we should throw that to Melanie.
Yes, it's certainly a challenge for those of us who are pushing to pass the New York Health Act. I will say there are great union partnerships that we do have. NISNA, the New York State Nurses Association, has been at the forefront of pushing for single payer healthcare in New York for decades. CIR is a big supporter. 1199 is supportive. There are several that are. I suspect when we reintroduce the bill, we may see maybe a little bit more. That's what I'm hoping for. I think it's very hard for me to tell you why unions aren't supporting. I have many theories, but it's difficult, right? I think sometimes it's a power game, sometimes it's a fear. They are definitely in some cases a barrier to success. But as I mentioned earlier about the importance of segmenting and expanding the coalition, look, the reality is that a lot of legislation that is deemed progressive, and we can all laugh, progressive, we're the only country in the world, only developed country in the world that doesn't have this, right? But I think a lot of that so-called progressive legislation really is driven by New York City. And I'm very much looking at other areas of the state to see what speaks to them. How do we build those coalitions so that we're not as reliant on, let's say, public sector unions in New York City? We've got to make sure we are building that support everywhere. But yes, look, definitely pay attention, follow us on social media, the Campaign for New York Health. As more folks, re-engage and, support, we will definitely let you all know.
Can I make a quick comment on that?
Of course.
Yeah, one of the things that I don't think has gotten out to the unions enough, or the public in general, is the whole structure of commercial or employer insurance paying 2.5 times or more compared to Medicare. And the Medicare proposals that are out there are talking about a 10% bump on Medicare and what would ultimately be a reduction in the commercial insurance side. Right now, employers and employees are getting hammered more than any other aspect of this system. And when I say 2.5 times Medicare, that's just the average. In our area, a local controller of one county investigated what he was paying as a self-insured entity. He's paying 6 times Medicare rate for certain procedures. I mean, outrageous. So any employer or employee or union that thinks they're getting a better deal with the system the way it is, they have the burden of the most pain in this situation. They're paying for and if you look at the cost of Medicare, it's roughly equal to the rest of the world. So when we talk about our system being twice as much as the rest of the world per capita, that's virtually all coming from the employer side. They're paying for it. So I think we got to get that reframing out there so unions really understand how this system is truly treating them. And we won't even get into how it impacts wages, where my executive producer, who owns a company, pays $15 an hour per employee on average before paying them 1 penny in wages. It's outrageous, but people are not really aware of what's going on, unfortunately.
So there are two connected questions. One of them is something I think everybody on this panel should disabuse people of. Somebody wanted to know about the rumor that she had heard that the New York Health Act would force public employees into Medicare Advantage. And the other concern, a related concern, is how can New York Progressive Action Network and the people on this panel help us fight the nationwide privatization of Medicare? And can anyone hear me?
Well, if you're asking about what I call disadvantage plans, I don't blame them if they're terrified of that. But I think one of the things that has to happen again with single payer, I'm not, to be honest, I'm not familiar with the New York bill, but you know, one of the things that has to happen is a leveling of the payments, you know, to Medicare, and frankly, getting rid of advantage plans has got to be a part of it, because they bring in all the garbage from private insurance into Medicare. And the vast majority of the public, once again, is not even totally aware of what these distinctions are. And plus, you get hammered by those hideous lying commercials on a daily basis.
Yeah, if I could just add to that, Catherine, I think, you know, the importance of education and simple messaging is really important, especially for folks that may not have so much experience with the system, who are just learning about it for the first time, who may be relatively healthy. We need everyone on our side, right? And I think something really interesting is happening with the United Federation of Teachers. For those who don't know, there was a huge city fight, and Mayor Adams essentially pushed them off of Medicare into a Medicare Advantage plan. Now, UFT is a very powerful union, not one, unfortunately, that has been a supporter of the New York Health Act, but I haven't seen retirees this fired up in a very long time. And I think it's about really making sure that we are ready to engage and kind of monopolize on these moments, right? And use them there. It's all in the media. We've got to use those flashpoints to educate our communities about, you know, the dangers of, you know, moving away from standard Medicare. But I think that's true of so many aspects of our broken healthcare system.
A number of people would like to see if the Maryland model can be applied to New York. And one of our activist friends asked, is the Maryland model of setting prices part of what is written into the New York Health Act? And please explain how the New York Health Act will bring down drug prices. And a related question is, what allowed Maryland to succeed in the limited reforms that they've effected, and how can that be replicated in New York?
Vince, I'll take the drug part. You can have the Maryland part. How's that?
Okay. Sounds good.
On the drug pricing front, the basic approach in the New York Health Act is that is to use the leverage and the purchasing power of 20 million New Yorkers to negotiate prices with the drug manufacturers directly. And the way we're looking at it analytically is essentially, you know, what kind of prices are we talking about? We're talking about prices that are, you know, basically 40% or 50% higher in New York than they are in all across the Western European countries. So it's a kind of a reference pricing model, but this has yet to be worked out. I'm just really talking about how we come up with what the approach is and what the parameters for the economic savings might be. And Vince, I'll let you talk away about Maryland.
Maryland can of worms. By the way, quickie on drug prices. Canada has a really simple program. That is, drug prices need to be within 5% of the average of the industrialized countries. So on one level, that's very simple and it does the trick. I'm not saying that's a solution for New York, but it's something to think about. Maryland is a tricky thing from many points of view. I struggled with this, you know, in making the movie. Number one, understanding the Maryland system, and number two, you know, it is very difficult to scale it in the sense that they never got rid of price controls from back in the 80s. So they have a totally built infrastructure with years of experience. And then what happened is the way the hospitals got around it, but was by mysteriously upping their volume. So Maryland ended up with one of the highest volume states, if not the highest in the whole country. So they had to bring in global budgeting to put a cap on what the hospitals were doing as an end run. So both global budgeting or some form of capitation and rate controls necessary. I would not, when we advocate for the Maryland model, we're basically advocating the direction of Maryland. It is not, you can't pick up Maryland and apply it to any state as is. What we're saying is the idea of rate control combined with global budgeting in some form or fashion specific to the particular state is the way to go. And studying this issue for 2-3 years, however long we've been on this film, I don't see any other way of cutting costs. You need, the rest of the world uses rate control and often some form of global budgeting. All of the talk about market solutions, I mean, it's, again, I can sometimes be blunt, but it's delusional. I mean, you need some kind of regulation. So I would look at Maryland as a kind of an initial model, but New York would probably have to do it their own way and, figure out what their own version of it would be. And even Pennsylvania, for example, has adopted global budgeting for our rural hospitals, but it's not the same as Maryland. They came up with their own version of it. So I don't know if that helps, but again, you can't just pick up Maryland and plop it anywhere for a lot of reasons.
I have a follow-up question from Melanie on this. Yeah, and I see maybe you're ahead of me because in your film, Vince, the hypothetical situation you described was like, what if hospitals and legislators and patients advocacy groups like got in a room together and came up with a rational system and set these price controls that you're talking about? Well, that's what the New York Health Act does. So Melanie, please expand on that and how this bill would answer that question specifically.
Yeah, thank you. And it's interesting. I've seen this film now 3 times, and that question has always come up. Maryland fascinates the crowd. Well, maybe that's what we should do. And I think it's really important to keep in mind that that's a piece of some type of piece of what we should do. We certainly need price controls, but let us not forget that, in my opinion, one of the more important pieces of the New York Health Act is that it ensures that everybody gets health care, right? And the Maryland model does not ensure that everyone gets health care. They ensure that there are price controls. So that's really important. And I think why the New York Health Act is so important for us here is because not only would it provide everyone health care, but it would give us the negotiation power, right? To drive down costs, to set costs, to negotiate and drive down drug prices, right? And I think it's sort of inherent in the bill itself that it will drive down and put in our own type of price controls.
Yeah, and I'm glad you mentioned that. That was another thing we struggled with, was how to integrate single payer. Because when we say Maryland is a good direction, without some form of single payer, it's still hugely problematic. I mean, to be honest, the people in the front end of our movie that are suffering from the system, they could be in Maryland with those problems. So Maryland is better in many ways, but yeah, until you have universal access, you have not really dealt with the whole problem in a serious way.
A couple of people felt you were being unfair to hospitals, that hospitals are being squeezed and you partly answered this before, that hospitals are being squeezed so much by what the insurance companies are both requiring and their restrictions that they have fewer and fewer alternatives. Do you want to speak to that?
I'd love to. Yeah, I'm no friend of insurance companies. Believe me, I think they should all be gone tomorrow, if not yesterday. But the problem is they're in a, it really depends on the hospital you're looking at. And if you look at the film carefully, we are defending a huge percentage of hospitals that are being hammered by the price differential. I mean, one of the fundamental problems in rural hospital shutdowns is not only is commercial insurance not paying Medicare rates, they're paying below Medicare rates. And the hospitals have no power to fight back against the insurance companies. So again, one of the dilemmas in this movie is for every statement you make critical of hospitals, there is another side. And we would love it, for example, if a lot of the safety net hospitals would come on board with this movie, because we're basically saying they're not getting paid enough. And again, like the employers, they're also getting screwed in this system. So it totally favors the dominating, powerful hospital who doesn't have the problem you're talking about, because they hold the cards in negotiating with insurance companies if they're big enough and strong enough. Like in Massachusetts, Mass General is the most expensive hospital in the Boston area. Well, if you're an insurance company, you can't exclude them. So, you know, they have you in a vice and they use it. So again, you know, it's the whole infrastructure we have going on here in payment that creates problems from top to bottom. And yes, I would say there are many hospitals that are victims of insurance companies, but that problem virtually goes away if you have some version of the Maryland system or some wise version of the single payer system.
No.
If
I
I could,
see you. Yeah, I was
Sorry.
just going to ask you what you wanted to say in response to that.
thank you. Yeah, and I apologize. I got kicked off and came back on here, but I did see that in the chat as well. They thought we were being unfair to sort of the H&H hospitals in New York City. And I think it's really important to learn the distinction, right? Technically, as you know, Vincent's movie shows us, they're all nonprofit, but they certainly don't all act like nonprofits, right? The public hospitals, I think the movie did a great job of talking to these safety net hospitals, the hospitals that really are still living the model of community-centered health. These are the hospitals that are struggling the most. And that is not who the movie is targeting. The
Not at
movie
all.
is trying to shine a light on these monopolistic hospital systems that are taking advantage of us. And I will say to, you know, Vincent, one of the most poignant points of the film for me was like, wow, our hospital system is not a place of healthcare. It's a business that happens to give healthcare, right? And that was really poignant. And it's something that we know, but you know, I think to your earlier point, we talk more about the insurance companies and big pharma and the influence of money in politics, and hospitals kind of get left out, and they are also big offenders. So I applaud you, Vincent, for really shining that light and educating so many folks. But that he was not going after the public hospitals. This is purely about the
Not at all. Not at all. I mean, I would, you know, just from my point of view, the public hospitals are noble. They are in a hideous battle. Once again, we have all these pockets of repression and unfairness in our system. Now, we couldn't get any currently existing public hospitals to come on the movie, because the other thing you find quickly when you're doing something like this is no hospital wants to come on board with anything that's going to criticize other hospitals. It's just, you know, it's the kind of secret rule that they're all following. So we were only able to get retired CEOs, but yeah, I mean, public hospitals across the board would benefit from some version of what we're talking about here. And as Alan Channing, who's in the movie, used to run Bellevue, said, all of the funding is designed to survive and not to thrive, and barely survive. So those hospitals are pitifully funded, and that was part of the basis of the gross differential in treatment in COVID. You know, it's really, some of this stuff is really simple. Those hospitals were underfunded and other hospitals were overfunded. And if you landed in an underfunded hospital, you were in trouble. And not the hospital's fault at all at the end of the day.
I have a follow-up question. Vince, you just described the difficulty in getting people from public hospitals to speak on the record about this. Maybe you encountered the same thing with private hospitals, maybe to an even greater extent. But I'm curious to know whether you came, where you spoke to healthcare providers. You had a nurse with a public hospital speaking deeply about the shortcomings of healthcare in that context. But my sense is, especially with younger doctors, even at these big monopolistic private hospitals that are raking in tons of money, there's a sense of unease, of dissatisfaction with the system, and of being a cog in a huge corporate machine, and not having a lot of autonomy. Did you come across this in doing your movie, and is that something that the movement could leverage influence these hospitals?
That's a great question. Because now so many of the doctors are owned by the hospitals, they're essentially under a gag order. They can't talk against the hospital at all. And and there's tremendous dissatisfaction in that side of things now. I mean, doctors aren't necessarily saying this on the record for obvious reasons, but they're discouraging their kids from going into medicine because of how corrupt it is. Not corrupt, but it's intruded profoundly on the practice of medicine. My doctor, for example, who is a relatively powerful practice in our area, so he did not have to get bought up, but he had a big patient base from years. If I go into him and he wants to spend 30 minutes because he's decided that's what I need rather than the 15, he spends the 30 minutes. He may end up eating it because the insurance isn't going to pay for a level 3 visit, but that's the way he does medicine. Okay, if he was employed by the hospital, they would say, what's going on here? You have 10 minutes and that's what you do because that's all we can get paid for. So that's just a tiny metaphor for the whole system. But a lot of physicians are very unhappy on a lot of levels, but some are not. I mean, the other day, somebody was telling me they know a doctor who's thrilled to death that he doesn't have to deal with insurance companies anymore and gets paid well and blah, 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 blah. So I'm not saying it's universal, but there's a lot of dissatisfaction. And we had a section on that in the movie, but I ended up cutting it because you end up having to focus narrowly, and we wanted to pretty much stick with the payment system as the fundamental issue. But buying up doctors' practices has undermined medicine in many ways. Plus, it doubles the price for that same exact visit you did the year before your doctor got bought up.
One questioner wants to know how many independent doctors are left, Vincent.
Peter, do you know that one? I'm not. I've read different accounts.
Yeah, no, I do not know the answer to that question, but the number is getting smaller and smaller and smaller.
Yeah.
I mean, it's clearly the minority at this time.
I would say from way back, and I wouldn't quote me on this because I don't remember the data on the top of my head, but something tells me maybe 60% are now owned. But there's this other thing going on now where financial institutions are also buying doctors' practices. So, that's a whole other thing that's happening. But interestingly, if you remember, the guy who was in our movie, who's a former hospital CEO in Maryland, he refused to buy doctors' practices. He considered it to be not a good idea. And again, this guy is as pure as any CEO you'd ever want to meet in terms of the way he ran his hospital. So he decided that wasn't the right thing to do for patients or the doctors. And but as far as I can tell, he's probably a lone wolf on that one. And most boards would not be happy if their CEO made that decision. And we got to remember.
Someone also wanted to know.
Yeah, sorry, one last point about that. The other thing we have to remember is that buying up these physicians creates a feeder into the hospital. So that's the other thing they're doing. It's not just economic power and raising prices, but it's a feeder into the hospital. So again, it's not driven by healthcare, it's driven by, their own self-interest at the end of the day.
Catherine, did you have another question? Okay, she might have cut off. So I think we're gonna wrap up here in just a minute. Is there anything that any of our panelists think we left out tonight? Anything you'd like to say before we wrap up?
Yeah, I'll try to make it brief. One of the things that was really important to us was to give people who watch the movie an option besides the big picture, price regulation and global budgeting. So we had a local county controller in our area who saw the movie and decided to investigate how much they were paying. I think I referred to that earlier. So that we're hoping is going to be the basis for a lot of our local activity to get other governments and businesses to start looking carefully at what they're paying hospitals, getting involved in accountability, community benefit, all of these issues. Right now, the public tends to be very passive. And again, I'm not speaking for New York. You guys tend to be more active than the rest of the country. But in our state, in our area, you know, people just float along. They pay the prices. They do not even think about what a hospital owes the community as a nonprofit element. So we're really trying to organize local activism to start getting involved, even getting members on the board. You know, 2 members, 3 members on a hospital board that think like us can have a huge impact. If nothing else, somebody's looking over their shoulder and looking at what they're doing and questioning what they're doing.
Thank you, Vincent. Melanie or Peter?
No. Okay. I just want to say thanks to everybody for watching tonight. Thank you to Vincent for making this film and giving us an opportunity to explore this discussion further. And thank you to Peter for your amazing financial analysis. You know, many of my mentors always cite your work. So I think it's, you know, I just want to say for those watching, NIPAN really knocked it out of the park tonight and pulled together a stellar panel. I hope you are as inspired as I am to get involved, get in the fight, join NIPAN, join our fight for universal health care in the state of New York. Thank you so much.
So following up on what Melanie just said, a number of people, this is encouraging, are eager to get copies of the film to disseminate to other people. They want to know how they can do that. They want to know how they can get hold of your other films, Vincent, and they want to know how they can disseminate this discussion as well.
Okay. So that's music to my ears. That's what we want. That's why we do these movies. So all our previous movies are all available now on our website, which is fixithealthcare.com. And then the new one, we are starting to organize community screenings. So maybe we do that through Melanie. I'm not sure who. If you get a list together of people that want to do screenings, we'd like to do that more formally so we can keep track of what's going on, where the movie's going, et cetera. So if you're up for that, Melanie, maybe you are our person. I don't want to give you the assignment, but I'm suggesting.
No, I think Catherine's a bit ahead. I've already had organizations reach out to me as well as legislators in New York, which is amazing, that have reached out to ask for the film. So yeah, we'll be definitely in touch. I'm happy to do that. Great.
And by the way, we're in the process of organizing screenings for the House and Senate in DC. So, you know, we'll be getting major viewings from them as well.
Fantastic. Peter, any last thoughts?
You're muted.
I just wanted to thank you guys for putting on this presentation this evening. It's been an honor to participate. So thanks everyone who showed up.
We love what New York is doing always. You guys are right there with California, if not slightly ahead of them.
Yeah, the race is on.
Yeah.
Well,
frankly, to be honest, we don't care who gets there first.
You're right. That's right. Well, thank you all, our panelists. That was a fantastic discussion. Thanks everybody for joining tonight, all the great questions that you posed to our panelists, and thanks for tuning in and getting involved. George, would you like to wrap it up with some last thoughts on NIPAN and what people can do going forward?
Go to nipan.org and join our organization. We have chapters everywhere, and if you're in an area where we don't have a chapter, we'll help you organize one.
Fantastic. And Ting, I think you also wanted to mention the screening we have coming up, and maybe also.
Yep,
give
I'm going to
fun-
drop a link in the chat right now.
Nice.
It's called To the End. It's a fantastic environmental film you can't miss. It'll be on July 31st, and we'll be sending out notices about it soon. So join us July 31st at 7 o'clock. There'll be some famous people in the screening and maybe with us in the room. That's it. I put a link in the chat.
Okay, great. And right above that is the link to the where you can donate. To your donation tonight will be split between the Campaign for New York Health and the New York Health Act. NIPAN. So thanks again for everybody for joining. Thanks again to our panelists and to all of you. We are going to win this fight. We're going to fix this broken system. So let's do it. Have a
Thank
great
you
night.
all.
Ask New York Health.
Yeah.
Good.